Okay, good morning, afternoon, everybody. Welcome to another weekly research conference. Today's topic is all about patient engagement. As I hope you all have noticed, the activities around patient engagement at the Heart Institute have really been ramping up. Partially due to, the interest and engagement of our patients, which is really phenomenal. Partially due to leadership by researchers such as Cobey, who we'll hear from, and others, and partially because that is the modern and best way to do research, of course, is to hear from and include the people who are not only impacted potentially by the research, but for whom the research, we are all dedicated to improving cardiac care and others. So today we've got a tripartite of presenters. We have Cobey, who's a scientist here at the Heart Institute. We have Sheila Gariepy, who is a patient partner. And we also have Heather Lannon, who is our patient engagement expert within the research services team. So we've got three fantastic perspectives on patient engagement in research, and we're looking forward to all of them. So first, starting with Kelly, she's a scientist here, and she leads the meta research and open science program. So Kelly's work is not just on patient engagement, of course, and the best practices, but all ways of engaging in research, sharing data, being inclusive, making sure that our research is at its most sort of topical and ethical, and including the people for whom it is designed. So her topics of interest in the lab are implementation of open science, reporting, data quality, data management. She is most recently been appointed to the National Committee of, hold on. It's not here. I'm going to do it by responsible conduct of research. Yes. As well as other aspects of research security, such as various sensitive topics in research and how best to engage them. And something we're particularly proud of here at the Heart Institute is that Kelly is the co-chair of DORA, which is the Declaration on Research Assessment. And DORA is an international initiative on how we best determine, measure, and promote the impact of research. So not just impact factor, not just publication, not these fancy metrics, but actually truly the impact. And so that's something that Kelly co-chairs internationally. So Sheila Gariepy is a patient partner and has been on a variety of clinical care, educational, and research projects within the Heart Institute, the Brain Heart Interconnectome, larger projects such as through UHN and U of T on heart failure. She's the former director of environmental and social programs within the government, and that is where we really draw on her skills in both analytical and communication, as well as project management and things like that. So patient partners don't just come here with a perspective of a patient, but in fact, they bring all of their skills that they have in their non-patient lives to the work that we do. So as a patient here at the Heart Institute, having family members with different cardiac diseases, Sheila's contributions have been informed not only by her lived experience and understanding, but of course, how that impacts patients, families, and caregivers. And last but not least, Heather is the Patient Engagement and Research Quality Officer within our group at Research Services. And Heather has over 10 years experience of patient engagement through various roles at UHN and St. Mike's, different engagement groups, the Canadian Heart Function Alliance, and that's through HeartLife. Lived experience as a caregiver, has done her PhD in social sciences, where her research focused on experience of patients and caregivers. So when we recruited Heather as our patient engagement and quality officer, it was not only with the lens of somebody with a sort of a PhD that has this expertise, but also herself coming from some caregiver lived experience. So really just, able to bring a wealth of that specifically with the research lens to our research services group. So Three amazing speakers today. We're going to kick it off with Kelly. And then as per usual, people online or in the room, we ask questions at the end. So welcome Kelly first.
Thank you so much, Katie, and thank you all for giving your time today to attend. I'm really just going to start us off with a couple of slides to situate the session, and then I'll hand over to Sheila and Heather to share their sort of expertise and experiences. So I'm speaking about my own experience as a researcher engaging patients in research. And so to start off this conversation, I wanted to give a little bit of background in terms of how I actually got involved in engaging patients in my research. And it actually was through being involved in research as a sort of citizen science in previous years. So when I was working after my PhD, I was working as a lecturer in Scotland, and I'd earlier done my master's in England. I noticed that within the UK context, there was like a great sort of citizen science movement, a great sort of involvement of patients in research that I hadn't been exposed to previously in Canada. And so I, for instance, started to do litter picks and, combing beaches and counting trash and weighing it. It was a real like cultural thing in high school. Students grow up and that's part of what they do. And I really appreciated that sort of engagement of the community in the research process. And then when I came back to Canada, I wanted to sort of start bringing those themes into my own research. And I don't work directly in a clinical area. I do meta research, so research on research. So I wasn't quite sure how that would fit, but I knew that I'd seen it done in other clinical settings by researchers locally and beyond. And I'd seen citizen science done well. So I kind of just felt like this seems like something intuitive. Citizens and patients should be sort of involved in this process or have that opportunity. But I didn't get into it knowing exactly how I'd involve them or knowing exactly what value they would add to my research. So I would encourage you to kind of keep that open mind if you're unsure how you would fit a patient into your research. Maybe just give it a try and see sort of the mutual benefits added for you and these individuals. So locally, the first project at the Heart Institute that I was involved in, that I engaged patients in, was a study actually about patient engagement. So we're getting very meta. So I wanted to ask to what extent is patient engagement occurring in cardiovascular research? So, kind of getting a measure of the temperature in terms of how common is patient engagement in research. We know that nationally and beyond, there are strategies, for instance, from CHR saying that we should be doing this. There's value in doing it. You can, even request funds to do it. So there's this sense that this is something valuable. And I wanted to know, who's actually doing it? Does it differ in different cardiovascular research domains? And when people do engage patients in the research, how are they doing it? To what extent and in what aspects of the research are those patients involved? So this was actually, the study we're going to talk about today was actually the first study at the Heart Institute I did where I engaged patients. So I had a history before this when I was at OHRI of engaging patients in my research program. But what I found over the sort of years I was at OHRI, I made very close relationships with a network of patient partners, and I would always go back to them. So it was like the same group that I'd frequently go to. And if I needed additional folks, I'd use them to connect me to additional folks in the community. But something different happened when I moved here to the Heart Institute. I was suddenly, in my meta research program, trying in many lines of my research to focus in the cardiovascular space. And I didn't actually have patients that I'd engaged with before that had lived experience in that area. So previously I did a lot of work in the musculoskeletal health space. So I thought, okay, well, what am I going to do? And I was happy to hear that we had an office that could support researchers like myself in sort of facilitating patient engagement. This is before Heather's time, but it was, for me, I saw it as an opportunity to expand my network. So just as a scientist, when we go to conferences and we want to meet new scientists or engage with trainees that are coming up or, people whose papers we've read, I thought, okay, well, this is a chance for me to grow my network of patient partners and expand beyond the expertise of the folks I already work with. And so my research coordinator, Mark Albert, simply wrote to the patient office here and gave them a short abstract of what we're doing and said, like, given the emphasis on patient engagement in this particular study, we'd like to be sort of matched with 2 to 3 patient partners. And that's exactly what the office did. They gave us 3 names. We reached out to these folks. We had calls with them. We determined whether there was mutual interest. It was like an interview on both parts. The patient partners that I was matched with all had experience contributing both as research participants, but also as patient partners. So it was a great dialogue, and that sort of set us on our course. At the front end of the research process, something that I do, which I have found very helpful, is actually creating a terms of reference with my patient partners. So in the study around sort of incidence of prevalence of patient engagement in cardiovascular research, I did the same thing. And I feel it's really helpful at the front end to clarify both from my own perspective, but also from the patient's perspective, like what we're doing and what the expectations are and the timelines expected for everyone involved are. So it clarified when and how we would communicate. This is a big one. So I often find patient partners come very enthusiastically wanting to contribute. And then, you onboard them and we're ready to go. But the terms of reference clarified, like there will be gaps in communication, for example, during which we are, doing data extraction. And I found that was fine. Patients don't actually care if you don't need them for a month or so when you're doing other things. What they care about is not knowing what's happening in the project and not knowing, should I reach out? Should I not reach out? So the terms of reference helps to clarify this at the front end. I also in it specify a payment rate and a schedule for that. And it was really interesting in this particular project, the patient partners, when they reviewed the terms of reference, actually asked for modifications to it. So it's very much a dialogue that we agree on at the front end of like, this is what we're doing. This is how each of us will be involved. And this is how we'll respect communication within the team. So the patients requested, which I think is brilliant, the payment be associated with milestones in the project as opposed to hours worked. And I think this works for a variety of different reasons, but one is that sometimes the nature of being a patient is that your health is a bit precarious and you don't know, what you can do this month may not be the same as next month. So by tying it to outputs, they felt more flexible in sort of how they would contribute their time. In this particular program, I paid the patients $45 an hour. This is very much in line with many recommendations, which are around $40 per hour in our national setting. This particular study was not funded, so I used some of those startup funds, thank you to the Institute, to pay my patient partners. But you actually can, of course, request this in grants. So it's very normative nowadays to request funding to support patients' reimbursement. And on that note, I just wanted to add as well, in previous experiences with patient partners, I always meet with the patients. I always like to have at least two on all my projects, so they have a bit of dialogue and a bit of sort of a peer to discuss things with. But I always meet with them individually pertaining payment, because the different circumstances of different patients may be such that they're not actually able to accept payment. And so we can privately have a conversation on what type of setup might work better for them. For example, if someone's receiving disability benefits, payments over a certain amount or in a certain period may be problematic. So there's ways we can work with their situation to find a way to reimburse them. And then still further, some patients just don't want reimbursed at all. And that's something we can also acknowledge and respect too. So as I mentioned, it's critical to keep patients updated on our progress and our delays. So I say mind the gap. So many of the patient partners we work with do have experience in research, but many don't, right? So very basic sort of research protocols, like the timing of the REB review time, may not be known to them. So, they may find it strange that, we submitted that REB 3 weeks ago. Why have we not heard back? If it's not your space, of course, they're not going to know, right? So again, making people aware and sort of narrating the process of what you anticipate happening can help create a mutual understanding for everyone. What we did in our team, the work that we'll present around the prevalence of patient engagement in cardiovascular research, is that we actually met with the patients and provided them with regular updates. So Mark Albert on my team and a co-op student at the time, Kaylee McKinnon, would meet with the team. They'd have a presentation, and we would just say, okay, we've screened this many records, we've extracted this many, this is sort of where we're at, this is how we plan to map our time into the future. We expect sort of data extraction to be done at this date, a manuscript at this date, and so on. So that was a very evolving process, as research always is. but we had those touch points to sort of update the patients, and they would then know how we would need them in the future. Okay, so that's a bit of the background in terms of how I started to involve these patients in my work and the terms of reference that I use to, I think, establish strong communication and expectations on both parties up front. We beg the question of, how can patient partners contribute? So if you're sitting in the audience or tuning in online today, and you've actually never engaged a patient partner in your research, it can seem a bit daunting at first because it's like, what is their role, right? We have a methodologist. The methodologist does, the method support, or statistician does the statistics. Like, where exactly do the patients fit in? Well, I would say that it totally depends on the project and your needs and the expertise of your patients. But to sort of meet folks at the front end of your research is really helpful to establishing how they can add meaningful value throughout the course. In the case of my project, we did meet at the front end sort of before a protocol was even drafted. And literally the scope of what I included in my study changed. So we were looking at, prevalence of patient engagement across a range of cardiovascular areas. And the patients were very adamant that we should have sort of an area or a bucket of articles on valve disease, because they didn't feel that they were represented in the other buckets. So we did that. So we modified our initial plan and accommodated that. In terms of this project, I also did way less writing. So in our paper, sorry to sort of steal Sheila's thunder, but there's not a lot of patient partner engagement happening in cardiovascular research. And as part of our paper, we have a call to action at the end of our manuscript, which is in the form of a table with different interest holders and what they can do to promote more integrative patient engagement. And I wrote virtually nothing in this table. So this was something that the patient partners really led. They had their ideas of what different actors could do. And they even illustrated it with examples of actors in that space already doing it. So it was great. I really had a very hands-off approach and was able to sort of review and add my own value. But definitely, I feel like there are networks in the patient space considerably enhance the quality of that table in a way that I couldn't have done on my own. Also for my project, my knowledge mobilization plan expanded quite substantially. So, this was not a funded project. It was something that I thought would be a cool mapping to do, lay of the land on patient engagement. I had no real intent at the front end of concrete sort of conference attendance for this output. But the patients did. So they attended the Canadian Women's Heart Health Summit, where they created a poster. I literally was very back end contributor to the poster. The first draft was done by them. All revisions were incorporated by the team. They presented the poster. So I felt like, part of the team, but certainly not the leader on that. And it just wouldn't have happened if it wasn't for the patients. I would not have had the capacity or the ability to attend, particularly the summit during that time. So it was a huge advantage. Similarly, we're going to be going to the Canadian Cardiovascular Conference this fall. There's going to be a panel session on patient engagement. Again, I've never gone to that conference before. I'm a meta scientist. It's a new community that I'm connecting with and having an opportunity to engage in highlighting this work in that particular venue, which I wouldn't have otherwise done. Even today's session would not have happened. This is not something I would have done a whole round session on. I probably, would have gone, published our article and moved on to something else. So you can really see how, especially I think the front end engagement, I feel like we all really see each other as a team. This is not some, now that we found something, we need a patient to stand up and say why it's important. It's from inception. It's been a team effort. So it's been very helpful. Here on the screen, you can see the track changes that Sheila, who will speak next, actually made on this is just the abstract. She has many comments throughout, and it's enormously helpful to have had this and that engagement at the front end. So does patient engagement really take more time? I've talked about sort of how I got started, some of the administrative stuff, some of the benefits to me. In terms of whether it takes more time and is, in an already stretched landscape for many researchers, I give you the word Jein. So some of you may know my husband is Austrian, so my family speaks German at home. So Jein is ja and nein, so yes and no, and it's combined. So it's Jein. And so yes and no. Patient engagement takes more time. On the one hand, setting up those upfront interviews, identifying patients, doing meetings to keep them updated on the progress, incorporating these comments that they provided. For sure, it took more time. It forced us to sort of slow down and think about these things at the front end of our research in a way that we don't typically do. So yeah, it took more time. But then at the back end of research, in particular with this particular group, there's been so much more effective and more diverse knowledge mobilization, of which I had limited contribution to, and is done to a very high standard and in excellent audiences. So it's something, in that way, I don't know if it actually takes more time. There's a quote from a late statistician at Oxford, and he says, we need, it's Doug Altman, so he said, we need less research, we need better research, and we need research done for the right reasons. And I think my experience with this project and patient engagement more broadly really reflects that. It may take a little bit more time, but in the end, I think the product we've created is of greater value and is being mobilized in the community in a way that it would serve as best as possible. Okay, last slide before I hand it over to Sheila. What can patient partners contribute? I feel like I've sort of alluded to this. You just need to have a conversation with them. They'll tell you sort of what they're interested in. I've worked with patient partners before who at the front end have very clearly stated they're not interested in public speaking. They will not be presenting this work at the back end, but there's other things like creating the poster or other types of engagement they are interested in. So you can just have those conversations and not sort of assume what your patient partner would like to do or has the skills and expertise to do. The other point I wanted to make before concluding is that I feel like so many of us fail to acknowledge our patient partners have many hats that they wear. So, some of them are actively working in particular professions, others are retired from professions, and they come to you not as just a person who had lived experience with cardiovascular disease. They come to you, perhaps as a parent, a partner, they may themselves have professional experience in research. I personally have had sort of experiences with patient partners, one of which is a copy editor. That's super helpful when you're writing your manuscript. You can't like take that skill away from them. So engage them for that as well. An HR specialist was the person who helped me create my original terms of reference for the patient partners that I engage. And right now I'm working with a retired finance specialist. So we have this big BHI grant, a very large budget that Dr. Jody Edwards and I are managing for our committees. And it's great, of course, this person is not sort of in the weeds of our budget, but, tools and tips, when they're coming to you, they can't take that hat off. So, I'd encourage you to sort of understand your patient partner as a more holistic person and the value they can add. Okay, so we'll hand it over to Sheila and then we'll be able to take questions at the end.
So Kelly introduced the study that she had engaged me and two other patient partners on. So it's a scoping review, looking at the literature to see how patient engagement is happening in research and also whether and how it's being reported in the journals. So this is the research team. You'll see my name, Helen Robert, and Anne-Marie Julian. We're the three patient partners. It's been clear from the beginning that we would be co-authors on this study, along with Kelly and a number of other contributors who have been engaged at various stages or in some cases throughout the whole process. So the research questions that the patient engagement scoping review was looking at are, to what extent is patient engagement occurring in cardiovascular research? And when it does occur, in what capacity is it happening? So to put this into practice, it involved a search of a number of tools like Medline and looking across the 7 cardiovascular disease areas, and looked at extracting 300 journal articles from 2023 on each of the 7 disease areas. And then I've outlined the basic information that was extracted. So what did we find? Very little evidence that there's patient engagement occurring. Either it's not happening or it's not being reported. If it's not being reported, as a patient, I would assume it's not being valued. So only 5 out of 2,100 articles even mentioned patient engagement. And of those, the information on engagement quality was very limited. No details, no patient partners were listed as co-authors in a way that could be ascertained. There was a combination of observational and clinical studies among the research studies that were captured in the articles. So what we concluded was that either calls for engaging patient partners have gone unheard, or they're not being reported, which means they're not being valued, but more likely it's just not happening. So a big gap between what we're hearing from the big funding agencies. CIHAR has a whole stream on patient-oriented research with lots of resources, information about patient engagement, but that in reality isn't what getting done, and that's not unique to Canada. Most large research countries have emphasis on patient engagement, but they're not reporting it. So there aren't mechanism and protocols driving this well enough to actually make it happen. So as Kelly mentioned, there weren't a lot of results out of the scoping review to report because there were only 5 articles and they had limited information. So we turned our attention to, so what? So we found this, what does it mean? Well, things need to change. So this is just an extract actually from the poster that was done for the Women's Heart Health Summit and from the journal article. So more effort to train researchers, give them resources, and find ways that they can get help when they are to support their patient partners and their engagement. The research organizations need to set the expectation that the research they fund will engage patient partners. They need to provide the policies and the guidance to the researchers, and they need to train. They need to provide training to researchers, training to patient partners, and they need a support person like Heather, who is there to help with the interface between researchers and patient partners. And what do patient partners need to do? Well, they need to build their skills and knowledge on how the research process works, how they can contribute. They need to be ready to clarify with researchers what the expectations are. And then they need to be prepared to talk about their own lived experience as it's relevant to the research. And also, it isn't here, but draw on the other skills that they may have. You know, I was one of the patient partners who said, wait a minute, why would we have a payment schedule that's calendar-based or hours-based when it's actually the milestones that matter? And you know, incidentally, you know, we're all heart patients as it happens on this project. And from time to time, we'll have a week when being a heart patient is the only thing that we can do. And we have to put aside other obligations, including patient partner work, until things get settled and we can kind of get our heads around doing something more intelligent than being a heart patient. Academic journals and publishers, they need to be setting the expectation that researchers will report on patient engagement, engage patient partners as peer reviewers. The British Medical Journal has had several issues focusing on patient engagement. It's a very explicit part of what they're expecting, and yet they're still publishing research articles that don't reflect that patients have been engaged in the research. And the journals have to incentivize research and perhaps be encouraging researchers to engage patient partners as co-principal investigators and co-authors. Funders, again, require and incentivize patient engagement, assess it, evaluate it, include patient partners on their review panels. The BHI has included patient partners as part of their review process. Transform HF, which is the heart failure research group in Toronto that I'm involved with, patient partners are full members of the peer review panels. We get the same number of proposals to review as the clinicians and the academics, and we sit on the committee. And I have had an influence on whether a study got published, because I was able to say, this is interesting for the researcher, but I don't think it would make a difference to patient care based on this experience and this experience. And the others are like, oh, gee, we didn't know how it related to patients. Thank you. Policymakers, again, they need to be requiring the medical research agencies, the funding agencies, to mandate patient engagement. And then they need to audit it to see if it's actually happening. So a good part of the forthcoming journal article addresses the changes we'd like to see in order to find out there in the real world the patient engagement that we thought we would uncover with the scoping review. So Kelly has spoken about how we were engaged in this scoping review. There were 3 of us, patient partners. Incidentally, as far as I know, there were like 1 or 2 men on this entire team. It was mostly women. That's just a coincidence. We co-developed the patient engagement terms of reference, the compensation schedule. Kelly talked about the regular update meetings. If we hadn't heard something for a while and one of us had a question, we'd fire off an email to Mark, Kelly's research associate, and we would get back a response and say, we will have something for you in a couple of weeks. Let's start to plan that meeting now. When Kelly talked about making presentations to us, all of that work that was being presented was part of the study. We weren't creating extra work for them I'm pretty sure we weren't, because the tables that show in the research methodology write-up for the study are the tables we were seeing as we went along. And we certainly participated in interpreting what the results meant. And as Kelly said, we've been involved in writing the manuscript and took the lead on the proposing and developing the materials for the conference. So this is the poster that went to the Canadian Women's Heart Health Summit at the end of April. The suggestion came from one of the patient partners. Another patient partner took the lead on drafting the proposal, the proposed poster, the text and the imagery. And everybody in the core group, the 3 patient partners, Kelly, Mark, made comments on the text. By the time it was done, it was a group effort. Kelly was letting us run with it, but she was also contributing to the wording. I don't want her to sell herself short. So I'm going to turn it over to Heather now. And if you've got any questions about that, we can field them at the end.
So thank you, Sheila and Kelly. Great example of the wonderful work that patient partners can play here at the Heart Institute. So what I'm going to do now is kind of switch focus a little tiny bit and talk a little bit more about patient engagement at the Heart Institute on a broader scale, where we've been, where we're going, and how we can support you in your projects and your work. So what you see here on the screen is something that I really want to drive home, the value of the lived experience. And I think both Kelly and Sheila did a fantastic job of highlighting that. And when we're talking about patient engagement, as Kelly said, it's not just I'm a patient, I'm a heart patient at the Heart Institute. It's all the other skills that patients bring. They're bringing a perspective of, does this actually matter to the patient? Is this research question relevant? Does the impact of what you're doing actually impact patient care on the end of the spectrum? So really looking at a different perspective and looking at projects and research in a different light. So the spectrum of engagement is something I took from this that I actually brought along. It's from UHN, and Sheila talked about UHN and the work she's doing with them. It's available online, but I recently attended a workshop where they kind of went through this and really highlighted some important pieces. And what you'll see here on the top is inform, consult, involve, collaborate, and empower. And that kind of shows us the wide spectrum of patient engagement that we can have. What Kelly and Sheila were talking about was moving towards the end of that arrow. And what we're hoping to do is that every project will start and kind of flow through this channel. And we'll see patients not just being sought for as a name on a grant, or not just being listed as a contributor, but really coming towards this collaborate and empower piece where they're making decisions, where they're, you know, producing a poster similar to what Kelly and Sheila spoke about, where they're part of a working group, where they're meeting with the team and discussing ideas and talking about the scope and direction of the project. We also had some examples about different roles that patient partners can play. And I think this is really important because I get a lot of people wanting to engage patients, and I think that's fantastic. People contact me all the time and say, I want a patient on my research project. And then I said, oh, okay, well, what's the patient gonna do? And then it goes silent. People don't know what a patient partner can do and what the roles might be. So here are just some examples. And I really like, again, it's from this toolkit, how they've laid them out into kind of 3 distinct categories: plan, do, and share. And, you know, really looking at research priorities, identifying what is important to a patient, what is important, what has impact, what really makes sense, what do they want to know more about, what's going to impact their care. Looking at the doing, and I want to highlight here, we're not training patients to be researchers. You guys are already researchers or trainees. We're providing another perspective. We're training them to be part of the team and getting them involved and really using that lived experience, that knowledge user, that end user expertise that they carry. So getting them involved with maybe helping get the study out there. We're not having patients go out and recruit patients, but as Sheila and Kelly mentioned, these networks are huge. There's Facebook groups out there. Patients know other patients and are part of other groups that could possibly get more and more people involved. And then the sharing. I think this is a huge area where we can see patient partners really having an impact. And I think this ties in nicely with a lot of the work Kelly is doing through DORA, and moving from having publications be the center. And I'm not saying that publications aren't important, they definitely are, but moving to different ways of getting that knowledge out there, getting the knowledge to the end user, whether that's through the poster like Sheila spoke about, whether that's through maybe, you know, some type of journal article in mainstream media versus just really having things focused to an academic audience. And then meaningful patient engagement. I always try and stress the word meaningful. And I think that's really, really important because we want to make sure that people are actively engaged. This is not a passive activity, but something where they're providing input. They're not sitting back. They're actually part of the research team. And I went to an event not long ago, and one of the analogies that someone used, and it really stuck with me, was looking at patient engagement as a long-term relationship or a marriage versus a short-term relationship or a one-time date. And I kind of thought about it and I said, you know, that actually makes a whole lot of sense. And I think Kelly talked about patient engagement taking time. And I think that's really, really important. It's not something that's going to happen overnight. We need to, you know, have meetings with people. We need to find out what their interests are. We need to look at trust, respect, communication, people coming together with different skill sets. So much like a marriage and you date or court your spouse, you're going to date your patient partner and hopefully build a long-term relationship. And I think in the end that actually works a lot better. We eliminate a lot of the tokenism of just getting a name for a short-term project, and we have someone who's fully integrated into our program. It not only benefits the researcher, but it also is benefiting the patient partner. They know what your lab is doing. They know what your research program is about. They feel more valued. They feel that their input has a meaning and there's a point to it, and it's not just a check box or a rubber stamp. So really looking at them as an integrated team member. Some other things that I think are really important to note is about communication, which we've heard, but really keeping them in the loop. You know, as Kelly said, a lot of times patient partners don't know everything about the research cycle. So I remember one time I was working on a project and, you know, 2 or 3 weeks had passed and the patient partner was calling to see why I hadn't produced the paper yet. And I was like, this is a 3-year project, but they didn't know that. They thought that you do an interview, you collect the data, you write the paper and it flows, but they didn't know that. So making sure they're informed every step of the way. The other piece I think is important to mention is flexibility. A lot of times we expect patients, we expect the public, we expect people to come to us, and we expect them to fit into our 9 to 5, Monday to Friday kind of schedule. And that doesn't always work when you're working with communities or working with patient partners. Some of them, as we heard, might have full-time jobs, they might have families at home, and just being really flexible about when and where to meet, I think is going to make your relationship with your partner go, you know, a lot longer and be more sustainable in the end. So what are we doing for patient partners here at the Heart Institute? We have a number of initiatives underway. Katie mentioned some of them that have been ramping up recently. So onboarding, making sure that patient partners are fully aware of what it means to be a patient partner, providing them with a patient partner guide, toolkit. We provided a number of training opportunities so far, things like webinars. We had a big patient partner day here in February, where we had a number of patient partners come in and get some really in-depth training into how to be a patient partner, what that role means, and also hosting an opportunity for them to network and connect with some of the researchers, which I think wasn't just beneficial to the patient partners, but also to researchers who wanted to engage with patients and get to know some of the patients who might be interested in working with them. Our newsletter has recently launched in January, so we have a mailing list of patient partners where we can provide them with, if you have a study ongoing or something that you're looking for them to get involved in, we can send that out through the mailing list. And one of the things we heard from our February event that we just initiated was that patient partners want a space to connect with each other, learn what each other is working on, hear about positive experiences, and also perhaps share different ways they can get involved. So we began hosting like a drop-in session once a month that they can come to that space and connect with each other. And then what's out there for researchers? What's out there for PIs and trainees? Matching, I like to call myself the matchmaker. If people are looking for patient partners to be part of a project or a grant or part of a research team, certainly able to help match you with somebody who would be a good fit. I love having conversations with people just to brainstorm ideas. How can this person be involved in my work? Kelly showed the terms of reference she created. So maybe drafting things like this that would help you inform the patient partner of their roles, their responsibilities, job descriptions. Compensation comes up quite regularly, so supporting you to create budgets, going through different guides and recommendations on how to accurately and appropriately compensate the patient. And then really, I think Kelly had it on her slide too. You know, just kind of providing coaching. Ask the patient, what do they want to be involved in? You know, connecting with people and really figuring out a way to make this work so that it's meaningful to the patient partner, but also meaningful to the work. Oops, there we go. Should have said contact details, but it looks like that one didn't come up. But the last thing that we wanted to do with the time we have left is have more of an open discussion. Questions, answers, comments, concerns. Talk about, you know, what is it that we can do to support you? What are things that, you know, you might need help with? What are things that would work or that are missing or that would support both the researcher side as well as the patient partner side, and really find out about how we can engage more patients and make the work even more valuable. So I'll get Sheila and Kelly to pop back up, and we're totally happy to answer any questions or any comments, things you'd like to see where we're going.
There are a couple of questions online as well, so maybe I could start with those while others in the audience might be prepping their questions or thinking about their questions. So this is from Stuart Nichols online about the time commitment. Is there a perspective that anyone of you can provide, maybe Kelly, since you brought it up, about how more time now in advance saves time on the back end when it comes to amendments and things like that. So just wondering if front end loaded versus, you know, does it maybe save time in the end?
Yeah. Great to hear from you, Stuart. I think from my perspective, and it will vary depending on the study and the sort of goals of the program, but certainly I felt the front end investment was paid off sort of longer term in terms of this really taking a life of its own in terms of knowledge mobilization activities the patients engaged in. So yeah, I do think also establishing expectations and communication and relationship at the front end takes more time. So it will vary in terms of the roles of the patients, but for my projects, I think typically it is front loaded.
And then also from Stuart, asking in regards to the, and I'm just going to ask maybe anyone who knows what he's referring to, the spirit and consort reporting guidelines. So just, and the question was directed for Kelly and Sheila, whether or not those updates to those guidelines, which are now have items about reporting patient engagement, might have on reporting. So back to your study about reporting, do you think the guidelines, what do you think it was a reporting issue or a doing issue, as he calls it?
Yeah, a great question. So the checklist, I think, will help in clarifying reporting. So for example, it would be, I think, in the vast majority of these studies that we would have a line in the manuscript denoting that no patients were engaged, patient partners were engaged in the design, conduct, or dissemination of this work. I think obviously that's not the outcome that we want, but having the transparency in the reporting would be helpful. I personally feel like, obviously we can never know, but I feel like we're in a bit of an echo chamber. Those of us, certainly Stuart, who are really in this patient engagement space, in which, you know, there are policies being developed and tools being implemented. I think broadly speaking, our results would suggest that, you know, patient engagement isn't occurring in great frequency in cardiovascular research. And if it is occurring and people don't fail to report on it, like I would suspect that the degree of integration of patient engagement is sort of suboptimal.
Okay, and then we have 3 questions in a row about essentially how can we get involved. So we've got one about the first step of getting involved, contact information, and even a question actually from Jennifer Monahan about how can patient partners potentially outside of Ottawa find out about the research that's being done within Ottawa. So Heather, I don't know if you want to answer that maybe, and then we'll provide just a note to say we'll provide everybody with, you know, with contact info and things like that, but Heather will provide a little more info.
Yeah, absolutely. So yeah, I should have the contact details on the slide, but we can send them out after in the follow-up. So we can certainly get those out where we'd love to have people come on board and have a chat and find out what they're interested in and find a space for them. So certainly reach out and we'll provide some details for that. And then for outside of Ottawa, we actually do have several patient partners who are from other areas of the country. We get people here at the Ottawa Heart Institute from all over. So we've been fortunate enough to recruit some patient partners from other parts of Ontario, as well as other parts of Canada. So even if you're not in Ottawa, certainly reach out. We'd be happy to find a space for you. A lot of the work is done online. So Zoom meetings, virtual things, absolutely do connect.
Great. And yeah, I'll just echo that when we put out some calls for some patient partners, although it's still almost requires you to be somehow engaged already, which is a bit of the challenge, right? It doesn't sort of put out a call unless you already are in a network. But absolutely, our patient partners are many of them are outside of Ottawa. So I think that's just to kind of echo that. And then another question from Risa Mallory: how many patient partners would you recommend for a project? Is it influenced by scope, topic, or duration?
Yeah, all of the above. I always like to have two, and that's usually what I recommend. I love the buddy system. And I think that works really well, especially when we're trying to eliminate power imbalances and differences in the room. So if you can appreciate a patient sitting at a table with 6 or 8 researchers, it's nice to have that partner there to kind of bounce things off of. The other piece that's good is if one person is not able to make it, you still have a patient voice at the table. And that does happen, obviously, other times with, kids, life, illness. So definitely 2. In Kelly's case, you had 3.
Yeah, I think in my case, because the project was so specific to patient engagement, I wanted to have at least 2 or 3 on that project. But I always do too for the same reason. Like no one would ever question like why you have like 2 statisticians on the team, right? So there's value in having sort of duplication in sort of broad scope of expertise. And I just want to add, I think today is the first time Sheila and I have met. So yeah, we've done all of our collaboration despite her being very close to the Heart Institute online. So it's very feasible.
Yeah.
And I would just add that for the patient partners, when it's an ongoing project or a big project, it's really useful that there be another patient partner so that you can check if your interpretation of something is appropriate or if there's another view. Every patient has a unique experience, trust me. Even if you've got the same condition, you will have had slightly different experiences with how that's been managed and what your experience is more broadly within the healthcare system. And you're also bringing different other skills and backgrounds. So it can be very helpful if a patient partner thinks that they're not being listened to or something's going sideways, to have another patient partner that you can check in with to say, like, what happened at that meeting? Like, what was that? And if the other patient partner says, oh, okay, yeah, I know this that you don't know that helps to explain what was going on, that can be extremely valuable. Or the other patient partner says, yeah, we're not getting through. What are we going to do to make that work? Or is there something we don't understand that is the reason why we feel like we're in an echo chamber? So it's helpful to the patient partners and to the researchers for the reasons that Heather and Kelly just said.
Yeah, great. And I just add another kind of comment from Risa was also about maybe a mentorship ally. And that's kind of, I think, kind of what you're describing. And I know that within the Heart Institute, there are almost like patient partner champions, I wanna sort of call them, like patient partner pros, who often do a lot of this kind of work, Sheila included, right? On people who kind of have done it a little bit and can provide that kind of expertise. And Heather mentioned also our speed dating kind of event that we had, although you said we should enter marriage contracts. So I think we should be careful of, speed dating, but at least to get to know one another. And I think that also helps. It's a patient partner education as well to one another about how to sort of what the expectations are as well. So it's about, not just mentoring researcher and patient partner, but patient partner to patient partner as well. I think that's a good goal.
I call those patient partners super patient partners.
Yeah, exactly.
Because they've like leveled up and
Yes.
and they do provide that training. I've previously with new patient partners that I've never worked with and who've never been involved, I've paired them with someone like Sheila who has done this type of stuff before, and then they can have that sort of buddy system as you mentioned.
And then also just a follow up is how do we ensure diversity, patient partner representation? So the same lens is not always being used. And I can just say as a researcher, I'm always, as I mentioned at the beginning, you almost have to already have a bit of a, foot in to sort of hear about these things. So just thinking maybe broadly, and anybody in the audience too, how do we reach audiences that haven't already put up their hand to say, I'd like to be involved, right? And then, because maybe they don't even know it's a thing. They don't even understand that, never heard of it before. So how do we reach those people? Any comments?
Yeah, I can make a couple of comments and certainly others. I think for me, one really critical aspect of engaging broadly will be sort of, community-based research hubs to sort of get the message out. Like we need to be sort of boots on the ground in communities, but also compensation. So a lot of patient partners volunteer, and then this tends to get you a certain, a type or demographic of patient partner contributing. And so the diversity of that voice is pretty narrow. But I think compensation allows people's time to be respected, right? And to allow now that we can request it in grants. I think the culture on this is shifting quite rapidly, fortunately.
This question has come up the entire time that I've been involved as a patient partner, which is about 5 years. And I don't have the expertise to tell you how to access a more representative patient partner group, but I do know that we need to make progress on engaging patient partners regardless. And so I think looking at what the barriers are, looking for ways to address them. Frankly, the thing about being compensated is that when there's work to be done and Kelly has said, okay, here's the draft, I'd like your comments by next Thursday, and I'm working on 2 other patient partner projects for which I'm not being compensated, I work on Kelly's first because I have an obligation. I'm being paid. And so I'm not doing it because I need the money. I'm doing it because we have a deal. And when I also do it because I know that with Kelly, my input is listened to carefully. Maybe it's just a coincidence that little excerpt she put up, because we did a lot of work on a shared drive. So everybody could see everybody else's comments, and the one she picked had 3 comments that I put. All 3 patient partners made the same comment about valve disease missing from the initial categories of research that we were being looked at. It wasn't just me. But the diversity question is critical. There's a number of centers looking at it. I don't think anybody has found quite the best way to do it, but certainly engendering that respectful relationship between patient partners and researchers, and helping to educate the researchers on how to make that work can only help. So I think Heather gets stuck with the how to recruit.
Okay, so Emilio here. So thank you for the actual presentation, and thank you, Sheila, for your generosity helping everyone in here. So I have a question about, when I was at BHA, I asked this question many times, and I think that it's instrumental in the sense that we are asking students working in the lab to get courses on, biochemistry, chemistry, whatever thing, right? But I think core training in accessibility and social accountability is critical at the time of, interacting with patients, right? Particularly thinking about that medicine, sorry, Peter, for saying this, but it's based on curing the individual. rather than seeing an individual as a person, right? That dehumanization of the person beyond the patient is critical in this context. And about, like reaching out and, having patient contributions, it caught my attention that most of the contributions presented today, and this is not a criticism, don't take it away, is written, orally, right? But I was missing some different ways of contributing, right? What happens if you are working with someone who lost the ability to write? Are we enable those individuals? So it's like, are we truly enable patients to fully participate? Or we're just narrowed down to a certain population of patients, they still meet the criteria of, non-disabled, right? So I think that is an important point of reflection. What do you think about it? Yeah, anyone.
Well, that very point has come up in the context of some of the work that we've been doing on peer review panels. So where patients are engaged in peer review, as you can imagine, there are patients with lived experience of brain heart issues who are living with the aftermath of a brain illness, a stroke, something else that has a huge impact on what they need in the way of accessibility. And that some of these questions certainly are coming up. And there is, I've just been recently working on sort of help for patient partner peer reviewers, identifying the opportunity for them to request accommodation. But that applies to any patient partner, is looking for the ability to identify accommodation, getting some help with that from researchers, having a better sense at the beginning, again, on what's expected, so that they're in a position to be able to say, okay, but I'm going to need closed captioning on these virtual meetings, and I'm only going to be able to type my responses, or I'm going to need somebody to, I need a sign language interpreter with me if we're going to do these presentations. So again, researchers need more information about dealing with the needs of their patients generally. Cultural safety training for researchers. I have identified that when I looked at a research proposal. This was when I was very first getting involved. And there were assumptions being made about how patients would interact with clinicians at a certain point in their care. And it was like, wait a minute, you're talking about extraordinarily vulnerable patients here. Are you requiring cultural safety training of your clinicians so that those patients can feel as safe as they could be? So I think that there's an element of education for the clinicians and the researchers here. And I think there's the need to very much make the patient partners feel safe in requesting the accommodation and actively looking for ways to make that work. So I agree with you generally.
Comments and questions? Yeah, this is fantastic and great progress, in terms of bringing patients into research as a major partnership. So a couple reflections. One is, currently we're doing a James Linda Alliance project, involving patients with different experiences all across the country, but together, with the health providers and different researchers, to come up with a priority in research. And but I learned in this setting that when you have this kind of discussion and priority setting, the roles of individuals, in fact, change very dramatically. And so, the physician and patient, relationship is a very special one. But on the other hand, in this context, is very, very different, right? The patient is no longer the patient, and the physician actually think in a different context as well. And the researcher, actually takes advantage of this insight, relationship. So that's why I do think that having multiple patient representatives, if we can afford that luxury, is really important because of the perspectives are quite different. And then the other aspect is that, the training aspect applies to, we can train the patient, in terms of understanding some of these processes, but also train the health provider as well as researchers in these new contexts, so I think we assume that we throw, people together, things will just naturally happen. But in fact, it is actually a different role, this type of setting, which is quite enriching. The question I have is actually Indigenous and the diversity aspect. So we certainly have done now research, particularly during the pandemic, but now continuing on in terms of looking at ethnic minorities and the Indigenous folks in terms of the COVID and the vaccine interaction along COVID, and also chronic disease. And we did a lot of these studies with community leaders and kind of bringing things to the community. And I'm going to Iqaluit later this week as well to do community-based study. Yeah, so I'm trying to figure out what is kind of the best way to do this, because we have the luxury here in which we bring patients here to the research activity. But I think the diverse populations may actually require sort of taking place, these type of research activities in a different setting. Yeah, so I don't know whether you have any thoughts on that.
I think that's a really good question. And I think, and Kelly kind of alluded to it a bit when she said boots on the ground. And I think that's something that we need to really think about is, we need to go to people. We can't expect people to always keep coming to us and, connecting with people in this space. And I know, Peter, you do a lot of work with Malcolm King and his group in the Indigenous space and looking at different ways that we can connect and collaborate as opposed to us housing everything in this building and really reaching out and really making the connections. I think that's the only way that we're going to truly be successful. And I'll go back, I keep coming back to my marriage analogy, but not like swooping into a community in a one-stop shop kind of a deal, really building that relationship over time and looking at how it's beneficial for that community or that group or that population and not just us here. I don't know, Sheila.
Okay, well, thank you so much for recognizing the time too. That was a great discussion. I feel like we could go on for a while, but thank you so much to our presenters and our attendees and questions online. And more to come for those who want more contact information. We can send it out to all the participants of the day. So thank you so much.